Thanks for asking me to actually give this presentation. It's great to actually be sitting here talking about sarcoma while about 41 years ago I was in the same position as most patients with osteosarcoma, and hearing all this about orthopedics. Dr. Zuckerman's talk is amazing what has developed over the years. One thing that is really important is, number one, patients do survive. I guess just sitting here is a great indication that we do great jobs here. Second part is we are no longer doing amputation, and limb salvage is extremely important. And that's what actually most of the soft tissue sarcomas are all about with radiation, although there are other options that are available. So today I'm going to be talking about radiation treatment for soft tissue sarcoma mostly. To outline, I want to talk about what exactly is radiation, how does the radiation work, use of radiation sarcomas, what exactly is the process when somebody is actually referred to me, what do we do? What are the different radiation modalities, what are the machines that are used, and what's the best time to use radiation? Radiation is basically everywhere. From physics, we know that anywhere from electricity, there's some radiation there, all the way to the cosmic rays. Even light has radiation. So we don't think of radiation as harmful in most of these cases. It's when you go beyond ultraviolet that it could potentially cause damage. But at the same time, that's the kind of frequency of radiation that we're using for treatment of cancer. So what does radiation do? It causes damages to the DNA of growing cells, and cancer cells, that's what they do. They grow, and hopefully the radiation will cause some damage to these growing cells. Now, there are other tissues inside the body that also grow, like skin, like the GI tract, like the mucosal membrane. And if we point the radiation to these sites, there can be some damage to these tissues, and that's where we see some of the side effects of radiation. But fortunately, these side effects are minimal, and if there's any irritation of, for instance, the skin, after the treatment is completed, those irritation will go away. Now, the cancer cells are not able to repair themselves as well as the normal cells. So over the few weeks that we do the radiation treatment, these cancer cells will die because they're unable to repair the damage that is done. We can also take advantage of this to do a better job of controlling the tumor. Now, traditionally, when we were not as sophisticated, we used the radiation beam that we put on the front of the body and then the back of the body and radiated everything. The techniques that we have right now these days is actually much better. We have improved significantly the use of CT scans, MRIs, PET scans to better define what exactly is tumor, what exactly is not. So we can actually kind of figure out exactly the location and how well we can point the radiation to. Now, I should also mention that radiation is localized treatment. So if I'm treating somebody's leg, I don't expect to see any reaction in terms of their heart or lungs or even GI tract. So it's only affect the area that we radiate. There are two goals for radiation. One is curative treatment. The goal is to make sure that we can kill as many tumors as possible. And the other goal is palliation. If we are not able to cure patients, maybe we can actually help them out with some of the pain that they have. Maybe they have bleeding that we can help. Maybe they have a tumor inside their brain or in the lung that we can actually radiate, and we can get rid of those tumors with radiation alone. So those are some of the palliative cases. But in general, the main goal is to actually be curative. And the purpose of curative intent is to make sure that we kill as many cancer cells as possible. Now, the main therapy for sarcomas, for soft tissue sarcomas, is surgery. If I have to choose something for local treatment, it's not going to be chemotherapy, it's not going to be radiation alone, it's the surgery. As Dr. Singh has mentioned, the purpose of the surgery is to get the gross tumor out. Now, the negative margin, sometimes these tumors can come back. even with the best hands of the surgeons. So the purpose of radiation is to make sure that we clean up what's left behind. Now, the radiation itself, when we do this curative intent, can take several weeks, and I think we can justify that. Now, think of a tree that you see. The purpose of the tree, the surgeon is to actually cut the trunk of the tree as well as all the leaves. But there are roots beyond that. Sometimes these roots can be seen, sometimes they cannot be seen on microscope. We think that we got all the margin. We go in and we kind of take the entire roots out. There might be some other roots that are left behind. The purpose of radiation is to eradicate those. Now, I can tell you that we, as radiation oncologists, cannot cure sarcomas by itself with radiation alone. It takes a lot of radiation to kill a tumor that is even 2-3 centimeters. And in order to deliver the radiation to that area, it may require like 8 or 9 weeks of radiation, and that cannot be handled by the body. It will cause more harm. So we think a little bit of radiation and a good surgery can actually kind of prevent amputation. Now, how do we get radiation? We don't send our patients to the beach. There are actually machines that they have. So what's the whole process? Our surgeons, our medical oncologists holler to us and say, can you see this patient? And before that, in a multi-conference, we actually talk about cases. We say this patient may benefit from radiation, this patient may not benefit from treatment. So they're referred to us. As a radiation oncologist, I review all the images that they have. If there's any other test that needs to be done, we order that. And we look at to see whether the tumor is localized or it's metastatic. If it's something that is already metastatic, the utilization of radiation might be just palliation, or it could be that we may want to consider aggressive chemotherapy, and sometimes the chemotherapy or immunotherapy these days could potentially kill most of the tumor, and we may be able to use newer techniques with stereotactic radiotherapy to sterilize one area or 2 areas that might be out there. But in general, if there's localized disease, we kind of agree that patient needs to have treatment. We'll proceed with what we call simulation. Now, as I mentioned, the treatment usually takes about 5 weeks to 6 weeks, or sometimes 7 weeks, depending on the situation. And we want to make sure we do the treatment in the same area every day. It's extremely important for us to be very precise with our field of radiation. So before we do anything, we need to kind of make patient comfortable. We make devices that they kind of have, so we can actually get a good exposure of the area that we want to radiate. And we get a CAT scan with this. Now, the purpose of the CT scan is so we have some external volume that we can take a look at, and also we can 3-dimensionally construct what the tumor looks like. Now, if I'm looking at tumors before surgery, sometimes we actually get MRIs that we have available, and I diffuse those images with a CT scan. So MRIs, I can tell you, are much better images than a CAT scan. And we can see the tumor much better with MRIs. So what we do is we 3-dimensionally construct the tumor, and then we figure out the angles of radiation, how to hit the tumor very well with margins. And again, the margins are extremely important for us. And minimize the tumor radiation dose to some structures like the bone, so we don't cause fracture. So we can spare some of the skin, so we don't cause edema of the extremities. Once that is done, we go through a lot of process, quality assurance, make sure that what we have created on a piece of paper or on a computer, we can actually kind of verify that on a patient. So the first day the patient comes in, we go through a process called another simulation. And this time, what we have created from the CT scan or MRI, we want to make sure the fields of radiation are going to be exactly the same as what we intended. Sometimes there may be a little adjustment that needs to be made. So we do that before we turn the machine on. And then we turn the machine on a daily basis. So the patient comes in, we put them in the same position, The actual treatment is about 5 minutes. It's very fast. Usually when we do the radiation, it's X-rays that we use. And as you would imagine, if you go and get an X-ray, you're not going to have any problem. However, the amount of radiation you're giving is substantial. It's not just like one chest X-ray that you get. It's equivalent of maybe about 150, 200 of these X-rays in one session. And the effects are cumulative. So as time goes by, people may start feeling a bit tired, the skin may get irritated. Depending on the location, they may get some diarrhea. If you're treating the GI tract or pelvic area, they may get irritation of the throat if you're treating area in the head and neck area. Or maybe if you're treating the chest, it might be that they get esophagitis and get really severe pain when they swallow. And then once they're done with the treatment, we refer the patient back to our medical oncologist or surgeons to make sure that they're being followed. Now, the side effects that I talked about is usually these go away. They are temporary. They will disappear as they come. So we don't expect them to just completely disappear the first day after treatment, but gradually people are going to get their energy back and go back to normal. I did mention that we do go the process of simulation. Again, we want to make sure we set the patient up in the same position. If you're treating somebody's head and neck, we can set them up with field of radiation that you can see. There's a mask that we make. The purpose of the mask is so they're not moving their head. Or if you're treating the soft tissue component, there's a vac lock, this blue thing that you see, blue device that you see, it kind of helps to make sure that the leg is in the same position every day. Once we do that, we go through the process of planning it, and what you see is different colors here. Now, this is a treatment for hip that I am doing. As you can see, there are some areas that are red. Those are getting a very high dose of radiation. There are areas that are getting blue, which is an extremely low dose of radiation. So there's a cloud of radiation when we do this. The hot spot is going to be where the red is, where the tumor is, and as it gets farther away, there's going to be less and less dose of radiation, so it gets colder. As I mentioned, there's a lot of quality safety checks that goes in before the patient gets in there. Over at our institution, our work is triple checked. I'm sure that's the same pretty much everywhere else. We do double check the physics calculations, and then once the patient gets on the table, there are some quality checks that are done. We kind of do a lot of measurements. We take x-rays on a daily basis to make sure the lineup is perfect. And before anything is done, there is an extra set of eyes that actually check to make sure that the lineup is great. Now, the machine that we do the radiation is called LINAC, and this is actually the position of this LINAC changes. As you can imagine, the radiation is made in this device, and it actually comes from this end of the treatment, and it projects to the patient. Now, the way that we line up, if you can see, there is a red line on the patient. That's the lasers that will help us to kind of line the patient up. We use external beam radiation treatment in this situation. This is radiation that is coming from outside. So what has been done in the last 15, 20 years since I graduated? I think we have seen that the quality of the radiation has improved significantly. As the quality is improved, we are actually reducing the toxicity of radiation, and we are also improving the efficacy of the radiation. The treatment that we are using right now is IMRT for most cases. Sometimes we actually use 3D conformal radiation treatment. So what are the methods of radiation treatment that we have? We talk about 2D, three-dimensional radiation therapy, intensity modulated radiation therapy, stereotactic radiosurgery, intraoperative radiation, brachytherapy, and particle beam therapy. And on the particle beam, you may hear proton beam, which is like form of particle that is being used for the radiation treatment. Now, as I mentioned, in the old days, we used X-rays, and we basically set up a field of radiation with a square like this, and everything that we treated was true and true. So we treated the heart, we treated the lungs, we treated the esophagus for something, whether it was worth it or not. At some point in the past, we actually started using 3D conformal radiation. So we started using computers, and with the use of computers, we are able to three-dimensionally generate where the tumor is. This is a case of a breast cancer, but sarcomas are very similar to that. Basically, you contour where the tumor is, and then you contour where the normal tissue is, and then you put a field of radiation that goes through and through. With multiple fields of radiation therapy, you can actually kind of guide to deliver the radiation. You can look at what area of the body is getting what dose of radiation. So again, the red is hot. That means that it's getting a very high dose of radiation. The blue is cold. And if it's outside of the field, usually there is very minimal amount of radiation that is given. Now, one thing that has developed is with the use of computers, we have been able to use quite extensive calculations that were not easy before. And using these computations, we can actually, instead of telling the computer, this is the field of radiation I want to do, calculate, we tell the computer, okay, I want you to minimize the dose of radiation to this structure that is sitting right next to it, and maximize the dose of radiation therapy to that special organ that is there. So for instance, if you're treating somebody's tumor in the chest, spinal cord might be sitting right in back of the tumor, and you can actually see from this that tumor is in the cord might be getting like 30% of the dose, and the rest of the tumor where we really want the dose is getting like 95% of the dose. So that gives us more advantage. So we don't cause any complication. We don't cause any harm to the structures that we really try to avoid. And we do that everything based on the computer that we see. So before everything is done. Again, this is case of metastatic sarcoma to the spine. As you can imagine, this is like the chest cavity. The heart is sitting in front right there. And what you see is the cord is sitting right there, and the tumor is in the vertebral body. You see where the red stuff is? That's where we really want to push the dose of radiation. Now, you can see there are all these pedicles that are coming out. These are the entrance and exit dose of radiation through other structures throughout the body. But the amount of radiation that gets to these organs are going to be much, much smaller. So there's really minimal risk of any damage to the structures. Now, I'm sure you heard of CyberKnife. The CyberKnife is another device that pretty much does the same thing. It's like a moving arm that actually gets close to the body and delivers the radiation. There are some X-rays that are being monitored constantly. It basically does the same thing as the other form of radiation. It's just that it has a very exotic name, Cyber. And you can deliver the radiation therapy with multiple smaller fields. So it actually delivers the radiation to where you really want it and minimize the dose of radiation therapy to the other parts. And this is an X-ray that is developed by exposing with IMRT. Basically, the areas that got exposed a lot became darker, and the areas that did not get exposed a lot didn't get darker. And you can actually see that. You can see one of the greatest minds of all time, Einstein, doing an X-ray. That's how it was developed, by delivering different doses of radiation therapy to the X-ray film. Now, as we have moved on, we are actually getting much more sophisticated, and things that we didn't think were possible in the past, we are actually doing a lot better these days. Somebody who had metastatic disease from sarcoma to the lungs, the standard treatment for that is chemotherapy or surgical resection, depending on how many of these we have. Now we have another modality that can actually be helped. We can actually deliver very high dose of radiation treatment to the point that we can actually burn that tumor completely and control the disease. There are some studies actually looking at patients who have what we call oligometastasis. There are some patients who, even though they have metastatic disease, tumors that have spread, there are only maybe 1 or 2 or 3 sites. And these we think are different than somebody who actually has widespread metastatic disease. These patients can be salvaged. We can actually kind of go aggressively with local treatment, whether it's surgery, whether it's radiation, after chemotherapy, trying to actually get rid of that tumor in that area. And by controlling that tumor in that area, hopefully we can actually improve on not only disease-free survival, the fact that they can live a lot longer without tumor, but maybe we can actually cure some of the patients. So it's a very exciting time for us. Now, in order for me to do the treatment, I want to make sure that when I design a field of radiation, it's going in the exact same spot. So what you see, you want to make sure that you are actually able to reproduce on the patient. So when the patient comes in, we do a field of radiation, we do a CAT scan. At the time of the setup, we do one, and then we superimpose that CAT scan on the images that we obtained from the CT scan the first day before we did any planning. And everything should line up perfectly. There is a cursor that we have, and we move this cursor, and this cursor can actually help us to make sure that the lining of the patient is exactly the same. And if we need to make some adjustment, we'll make the adjustment accordingly. So if we need to move the patient up like half a cm, we'll do so. If we need to make move them to the right to make sure that the tumor lines up perfectly, we can do that. This is not something that I could have done about 20 years ago when I was coming out of residency, 25 years ago, I should say. Now, another thing that we can do is what we call IORT, intraoperative radiation therapy. There is a device that we have, it is called ZOFT. Basically, it's a KV X-ray, so it doesn't penetrate as much, but it does penetrate enough, like half a cm or 1 cm, along the field of where we put the radiation. And if our surgeon calls us and say, you know, there is an area that I'm concerned about that I cannot get the tumor out completely inside the operating room, we can potentially go there. I can tell you we use this for breast sometimes. We haven't done that for sarcoma, but I think that's something that can potentially be helpful if our surgeons ever call us. Now, I did mention proton beam. Proton beam is a form of radiation. It's a particle. X-rays don't have a mass, so if I put a radiation beam on front of somebody, it exits the back. Whereas proton beam, they have a weight and they have a particle has a mass, so it doesn't penetrate as much. But in order to accelerate a proton beam, it requires a massive amount of linear accelerator, what we call cyclotron. It's like 2-3 story building that you actually need to accelerate. And it actually costs maybe $100 million for the old machines. The newer techniques, I think we can probably get one for like $40 million. And if it has a lot more advantage than the photon therapy or the X-rays that we use, great. Unfortunately, there are only a few areas that it has a great advantage over the standard radiation that we use. Now, what you see here is the dose distribution of radiation treatment. This is for pediatrics case. In the pediatrics cases, we want to make sure we kind of minimize the dose of radiation therapy to heart, lungs, and a lot of times we actually treat the entire craniospinal. We treat the entire brain as well as the spine, but at the same time, we don't want to kind of expose the heart or other structures that are out there. As you can see from the images, the left hand has a much better distribution. There's really no exit into the heart or lungs, whereas in the right one, there is some exit. So long term, there can be some potential problem with use of photons, but proton beam can be quite improvement at that. The problem is proton beams, it's a lot more expensive. The insurance companies don't cover it. And to be honest, a lot of times we can actually do as good of a job with photons or what we have IMRT or SBRT that we don't have to worry about that. Now, I did also, I want to make sure that we also talk about brachytherapy. Basically, brachytherapy is, instead of giving the radiation from outside to the inside, you put devices, what we call catheters, inside the body where the tumor is. You have to lay them out next to the tumor, so it requires a surgery. And these catheters are left behind. We do a lot of calculations, and we figure out if we put a radioactive material inside these catheters, how long does it take to actually deliver a good dose of radiation that we want without causing any minimal effect. Now, the nice thing about brachytherapy is actually it works from inside out. So when we put a radioactive source inside the body in these catheters, it gets a very hot area, but it falls up much faster. So 1 centimeter to 2 centimeter dose of radiation is about 1/4 of what it is from 1 centimeter. So the fall off is going to be much faster, which translates to the fact that side effects or the late complication of radiation therapy can be minimal. What are the machines used in radiation therapy? You may hear TrueBeam, Versa, Trilogy, Synergy, Precise, CyberKnife, Proton, and even Gamma Knife. They're all basically, for most part, they're the same. I can tell you there are only 2 centers in California who have proton beam, one in San Diego, one in Loma Linda. I think the cost is overwhelming, and there's really a couple of areas that, in my opinion, are more advantageous to use proton beam as opposed to photon. Mostly in pediatrics, but sometimes in adults for retreatment. Now, I also did mention Gamma Knife here. That's something that we use only for brain, not for other parts of the body. When it comes to Gamma Knife, it's a form of what we call stereotactic radiosurgery. Now, we can also do kind of treatment, very high dose of radiation to a very finite area inside the body, whether, as I mentioned, it's a lung that we can do a treatment. It can be quite drastic and give a great job of high dose of radiation to eradicate the tumor. It's just that we need to be very precise with that. Now, how about the timing of radiation treatment? What's the best way of doing it? We can do it preoperatively, we can do it postoperatively, or we can do it intraoperatively. Now, the advantage of preoperative radiation before surgery is the fact that we give a lower dose of radiation treatment, and it's basically we have a tumor that we can see. So we can actually visualize where the tumor is. We can give margins, whether it's 3.5 centimeter around that, and then we can actually do the radiation. Now, once the surgery is done, we have to kind of account for the fact that the field of radiation might be contaminated. So we have to treat a little bigger volume. And one of the things that surgery does is actually it causes some hypoxia. There's not enough oxygen going to the tissue. There's healing process that is ongoing. Now, in order for us to overcome that, we have to give a higher dose of radiation treatment. So preoperative dose of radiation therapy is a bit lesser dose, better defined, whereas postoperative radiation therapy is actually higher dose. The advantage of postoperative radiation is if our surgeons take out a small tumor, which is well differentiated, we may not need to use a radiation at all. So we have avoided the utilization of radiation. But the main reason is we are not postponing the surgery. As I mentioned, the mainstay of the therapy is the surgery. So if you're postponing that for like 7 or 8 weeks, something can happen that is unavoidable. It can be avoidable.
2 minutes, please.
Well, I just want to make sure that everybody understands that radiation doesn't cause any tumor, any other problems more than what we already know. People don't have like 3 hands from radioactive material, and we do some harm, but overall, I think we have done great for the patients. So at this point, I'm going to stop. See if anybody has any questions.
Thank you so much, Dr. Hakimian. We've got time to take a few questions.
Great talk. This is very, actually, a lot of the questions I think were answered in your lecture, you know, so we'll get to some, you know, I think I think this is a good question. Is radiation useful or safe in sarcoma with Leaf-Romani syndrome? Should we avoid it?
So
There was given prior to a leg surgery to remove the pleomorphic tumor.
sure. So there are some people who may have some predisposing factors to cancer. Leaf-Romani is a disease that there's p53 abnormality. They may actually have prone development of cancers. And the last thing I want to do is actually cause some form of cancer down the road. So it's a balance between benefit versus risk. And usually we try to actually minimize the risk. If you know somebody is actually at high risk of developing cancer, we try to actually avoid radiation if possible.
And does the subtype make a difference to the success of ablation of lung metastasis?
It's a great question. I think we are looking at whether it's different subtype of cancers can respond differently. We think it's just the number of the lesions and how much of a lung we can radiate without causing any damage. So it's not just the subtype, but certainly the size of the lesion is important and how many lesions we have to treat. When we do the calculations, if you have like 1 or 2 lesions, we can eradicate those with radiation with minimal damage to the normal lung. But if you have like 6 or 7 lung metastases, it might be just prohibitive for us to do anything radiation-wise.
Okay, and do you feel that radiation might delay time when immediate surgical intervention would be the better choice? I think you touched on the pros and cons of radiation
before and after.
Mm-hmm.
Sure. So best example I can say is there was one Canadian study. This goes back to a few years ago when you have a hard time actually randomizing anybody to having surgery first or having radiation first. And Canadians were actually ahead of us in America, and they did one study that they did preoperative radiation, giving the radiation beforehand to lower doses as compared to the higher dose of radiation afterwards. The study closed mainly because there were a lot more complications with preoperative radiation. But when we analyzed the data, we realized that when we do a high dose of radiation postoperatively, there's a lot more fibrosis and scarring. So we cause some scarring which is permanent versus some wound dehiscence, which is something that people can eventually recover from. I think most people will actually take that wound dehiscence over complication of fibrosis. So most people think preoperative radiation is probably a better idea, but there are different circumstances and depend on the situation. I've done it both ways even recently. So,
is radiation for all sarcoma cancers? What about leiomyosarcoma?
Yes. So there is a grade of the tumor that's important. The size of the tumor is that's important. Superficial versus deep. If somebody has a very small volume tumor, very low grade, surgery alone should be adequate with a good margin. I wouldn't recommend radiation. If somebody has tumors in their hand, it would be a horrible thing for me to radiate, so I would recommend surgery. If leiomyosarcomas, there are different kinds of leiomyosarcomas. If you're talking about uterus, that's something that is a little bit controversial. We think as radiation oncologists that it actually improves on disease-free survival, it improves local control. But if the tumor decides that it can spread somewhere else, the outcome of the tumor spreading is the same, whether we can do a good job of controlling it. So some people think that they should not be getting radiation. They should get chemotherapy up front and omit radiation for uterine cancer. For soft tissue, I think I feel very strongly about using radiation treatment locally. For extreme.
And typically no radiation for bone sarcomas.
Osteosarcomas are usually treated with surgery and chemotherapy. There is a couple of other areas that could potentially be beneficial. One would be mandible when the surgery may not be feasible, spine, so the surgery may not be feasible. Under umbrella of bone cancer, there's also Ewing sarcoma, which is different subtype. Radiation is actually very effective for that. Problem with Ewing sarcoma, you can actually do surgery or you can do radiation. Either one of them locally can be as good, and usually we try to avoid radiation if possible, so surgery is done. But there are areas in the pelvic area that surgery might be causing a lot of morbidity. Radiation can actually get there and do a very good job of controlling the disease, or Ewing sarcoma.
Okay, and I think, and so there was a confusion about, radiation-induced angiosarcoma of the breast. They had a mastectomy. Why would radiation be recommended as part of the original cause? Wouldn't that lead to recurrence down the road?
Well, it's not a recurrence we think of when you actually resect a tumor. The main concern is local relapse, and tumors in the angiosarcoma, when you kind of resect it, there's a high risk of having the tumor coming back. So we want to make sure we take care of that. Not everybody who gets radiation is going to develop angiosarcoma. It's actually a minority of the patients, and that can be a lagging time, maybe about 5 years, 10 years, 20 years, that sarcomas develop. So if somebody is young, certainly that's a consideration, but I think the local control is more important.
And peer-reviewed research, especially the new guidelines released 8 weeks ago, say that post-op radiation for dedifferentiated liposarcoma in the pelvis or retroperitoneum is useless because it could significantly diminish long-term quality of life while adding nothing to OS or PFS. Do you agree with this?
One area that I'm mostly concerned about is utility of radiation for retroperitoneal sarcomas. These are very, very difficult to figure out exactly the context of where the tumor is, especially post-operatively. You are dealing with tissue that has been resected. You're dealing with intestines that you have to radiate over, and you can only give certain amount of radiation. So generally speaking, these days what I do is, if I do know that somebody needs to have radiation, I try to actually do it pre-operatively. Where I have a good target, I can actually push the dose of radiation. And sometimes these large tumors, ironically, push the intestine out of the field of radiation, and it can actually do the radiation with higher doses, even within the preoperative setting.
We got time for one more quick one.
Okay, let's see. What is the success rate for brachytherapy treatment post-surgery in cervical cuff for leiomyosarcoma?
That's a good one.
I want to, that one's like, we have no idea. But anyway, let's see what your answer is.
It's not a common recurrence that we see. Usually we think, depending on the extent of the tumor, if it's a small volume, we can potentially consider some brachytherapy for that. If it's a large volume, I don't think, no matter how much radiation you're going to give, you're not able to control that. So depend on the size of the lesion. And when it comes to the vaginal cuff recurrences, depend on the extent of the tumor. If you're dealing with like 2-3 millimeter margin, you can basically do the radiation through the vaginal area. If it's actually more than that, you have to put needles in, and that can be quite different than putting a cylinder in and doing the treatment. It's a lot more aggressive form of procedure.